I will never know everything about internal medicine. And that's okay. That's why we have other people to ask or to refer to, because I do refer. I've referred to some of the universities for equipment or for some of these people who are top in their field, because I would rather the patient get appropriate care. If I don't know how to do it, I'm just going to back away. And I think that keeping the patient in mind is more important than keeping our ego in mind.
Hi, guys, and welcome to the House Call Vet Cafe podcast. I'm Dr. Eve Harrison. I'm a full-time integrative concierge house call veterinarian in Los Angeles, and I help other vets to build their unique mobile practices on their terms. This podcast is for and by house call and mobile veterinarians, so it is meant to give our community a platform to connect, to share our stories, to lift each other up, and to support each other. Most of us work solo as lone wolves, right? So for me, it's been really powerful to be able to physically hear the voices of my colleagues from all over the world and to get a chance to feel that we truly are part of a community of very real other human beings who get it. While you may be alone in that little bubble of your own vehicle when you're on the road seeing patients, I welcome you to join our community by tuning into our own podcast when you're on your way to your next house call. Whether you're a super experienced house call vet with 30 years of experience, you're a brand new prospective house call vet just looking to get started, or you're house call curious, there will be something for you in this podcast. Each episode, you will hear interviews from other mobile veterinarians just like yourself who are doing unique and innovative things, vets who are sharing their stories, their struggles and challenges, and you can also look forward to hearing valuable information and perspectives from specialists and experts outside of our micro niche. And finally, if becoming a house call veterinarian is something that you've been thinking about exploring, or you're looking for some extra support getting your own mobile practice to feel more profitable and sustainable for you, check out the information in the show notes about my course and our above and beyond supportive private community for members only, plus our monthly group coaching sessions within the House Call Vet Academy. You can also check out my free public Facebook group, which is also called the House Call Vet Cafe, the same name as this podcast, and which is a warm and cozy community for mobile vets to support each other in professional and personal development, in creative entrepreneurship, and in friendship. So thank you guys for spending time with me today. Let's dive into the episode. Okay, everybody. It has been a little while since I released an episode. I am back on track. I am super excited to have with us today an amazing human being and doctor in my native area of Los Angeles. So today we have with us Dr. Tara Ghormley, who obtained her veterinary degree from Colorado State University. She pursued further training in specialty private practice, becoming board certified in small animal internal medicine. Dr. Ghormley worked in specialty clinics until recently, when she partnered with her friend and opened a mobile ultrasound and consulting practice. Her professional interests include immune-mediated disease and hematologic conditions. She lives with her husband in Agoura Hills, along with their cats, rabbits, and chinchillas. So welcome, Dr. Ghormley. I'm so glad you're here with me today. It's cool that we're doing this podcast because for those of you who don't know, which is all of you, Dr. Ghormley ultrasounded my cat just this morning, so she was in my house. And we were doing veterinary medicine together. It was fun. So welcome. I'm glad to have you here on the podcast.
Thanks so much, Eve. I'm glad to be here.
Yay. So can you tell me what's your favorite snack to eat in the car? Are you and Priscilla like in the car driving to ultrasounds, like scarfing all sorts of snacks, or like what is that setup like?
I'm not a snacker in the car. I'll have a granola bar. Priscilla has her coffee. I'm chugging down water, mainly just like bottles and bottles of water. I'm not a huge snacker in the morning, I think, when we're having our appointments, but we stop for lunch. So today we stopped for lunch after our appointments, which is really nice that we get to do that, so that we don't have to rush. We'll sometimes have a little break and we can go to a restaurant, sit down and do that instead of just eating on the go.
That's awesome. Where did you guys go eat?
We went to Barney's Beanery today.
Oh, I like that place. That's fun.
Yeah, that was fun. That was nice.
Very, very cool. So I wanted to hear a little bit to start out with. How did you kind of embark on your journey? How did you decide to open a mobile ultrasound practice a few months ago? It's really a cool thing what you're doing, because there are specialists slowly starting to also do the mobile practice thing and, or open up a solo practice. And I'm super excited that you're here in Los Angeles and that you're a resource for my patients as well. So I'm just really curious, what brought you to the mobile path?
That's a good question because it's not anything I ever thought I would
Right.
do ever. It was never
Right.
something that I was intending on doing. Really, what happened was I was just working a lot of hours at my clinic and physically could not keep up. Was just exhausted all the time from some chronic health issues and wasn't able to adjust my schedule. That just wasn't going to happen because they wanted me there the hours that I was there. And I knew I couldn't keep it up. And my friend, who is a veterinary technician, had an idea to start a mobile practice. And it happened to be at the time when I was looking for something else because I just was not able to continue with what I was doing. And it was the right time, right place, right person, and took the leap the end of last year to start the corporation.
Very cool. And so you've been open practicing how long now?
We officially opened in March.
Amazing. Yay.
So it's about 3 months now, 3.5 months. So not very long. It feels like longer because of all the
Yes.
stuff we had to do beforehand but yeah, not very long. So just a new practice for us.
Yeah, I want to applaud you for putting in the work prior to opening and doing it right. You really did. You took the time, like you said, the right person, the right time, the right place. I think it's such a blessing that you could start a practice with someone that you trust so much professionally and personally. And I think that's just a real, real blessing, you know? So I see that and I'm just so happy for you both because it looks good. You know, it seems like such a great setup and it's really fun working with you guys together too. You guys play off of each other and it's cool.
Yeah, I mean, sometimes for us it doesn't seem like work. Like today, we're working, but we're also having fun, and I haven't had that in so long. It's just a nice change. Just the stress that I had working all those hours, I don't have that. Even on top of the stress of having my own practice and having to deal with that, it's still less than what I was experiencing working full time in specialty.
Oh, yeah, there's nothing that can compare to the kinds of work that we get subjected to when we're working under corporate structures, especially specialists. Specialists get really worked to the bone, and most specialists are working within corporate structures, right? Almost all specialty medicine is owned by corporate now, right?
Yeah, you're pretty limited if you're a specialist because you do need the referral caseload. You also need the equipment. So it's definitely not as easy to just be a lone specialist. You really need those bigger hospitals. And unfortunately, those bigger hospitals are really no longer owned by individual people or just a group of people. They're really being bought out by these very large corporations. And then corporations are buying corporations. So they're just kind of all consuming each other. So yeah, as a specialist, you really have to pick which corporation you're going to go to. You don't really have a whole lot of options. My friend said I somehow figured out how to escape that, and that I did. And I'm really happy that I'm in control of my own schedule, in control of what I do and what I don't do, and don't have to push myself to the point where I'm just breaking.
I'm so proud of you. I wish more specialists could hear your words and know that they can escape too. Like you said, you can do
Yeah.
it. So I want to hear how it's going for you, but first I wanted to back up a little bit. I know just because we have a personal rapport that you suffered from long COVID and you had a lot of health issues related to that. And some of that played into, in my understanding, one of the things that kind of pushed you over the edge to leaving the environment you were in. Can you tell me about your experience with that? How did COVID affect you? How did it affect your practice and your decision making processes as to where to go with your profession, your career, you know?
Well, right after I got COVID and I was extremely sick, it was March of 2020. So it was very early. I was really sick. I was in the hospital and then I was sick for months and months after and had these lingering effects. And at that time, nobody really knew about long COVID. Nobody knew why I wasn't getting better. And we didn't know why my cognitive function wasn't getting better and why I couldn't breathe and any of that stuff. So I, at first, wasn't sure if I was ever going to be able to go back because I took 5 months off. And then when I did go back, I was happy that I was able to still function as a specialist and do what I really like. But as time progressed, it seemed like my long COVID just kind of got the best of me. I was pushing myself so hard. And one of the things with long COVID is sometimes you have just this post exertional crash where you do so much and then your body just fights back. And that's what was happening to me more and more and more. I was having these crashes, these flares that were coming every few weeks. They were kind of coming on schedule. And then first it was a couple days, then it was a week, then it was 3 weeks. So it just kept getting more and more to the point where I couldn't ignore my body anymore. And my doctors were pulling their hair out saying, you can't work these hours. You can't do this. This is not going to be something that you can sustain. And I fought that for years before my body basically quit on
Yeah.
me.
Yeah. That's such a common story. And your story is clearly a more extreme version of it. I mean, I think most of us are not dealing with long COVID and the issues that you've been dealing with, but so many veterinarians come to a breaking point when their body decides no more. Like we try to power through, we try and muscle through, we try and think our way through, resilience ourselves through, and the body knows what's up. And it's like, hell no, no.
Exactly. And unfortunately, having a chronic illness in this profession is not always supported. And so trying to reduce my schedule or reduce my caseload, it just isn't something that was happening, unfortunately. So I think that's a common thing also is that there's a lot of veterinarians with other chronic disease and they just really feel like they can't tailor their own schedule. They don't have control of their own schedule. They're being asked to work these hours that they can't work because physically they're just crashing after that. And I feel like it's really, especially in these bigger corporations where you just kind of have this huge HR department that doesn't really care. They just don't understand how it is to just have your body not be able to do this anymore.
Yeah, yeah. It's very much that we've become cogs in the wheel or in the machine, and HR sees us as expendable. We're commodities. Oh, this vet has a chronic disease. Screw her. We'll get one that doesn't. Like, what about the humanity? I mean, it's just so ironic to me that in the field of medicine, a healing field that we're in, there's no room for us to be sick. There's no structure to care for us or for us to listen to our own bodies. It's like completely backwards. It's like just wrong on so many levels. And it's kind of funny. I want to come back to something you said about the corporations eating corporations, eating corporations. And it's so meta. Like this morning, we had a really meta moment where Tara was ultrasounding my cat, and Tara is like a brilliant ultrasonographer. She does a 6-minute ultrasound. It's most amazing. She picks up a call from another vet who's working on her rabbit while she's working on my cat. So it's like this like meta, like us vets like working on each other's animals. It was just a really beautiful moment. But anyway, I just thought it was kind of relevant to corporations eating corporations. We're doing the exact opposite. We're healing each other's animals for each other on a one-to-one basis. And I thought that was just really kind of a beautiful and awesome moment. And I think just us collaborating and you being on the podcast and working on my cat and one-to-one respecting each other as professionals is such a beautiful return to what I think veterinary medicine could be, right? Instead of we're humans, that's part of our well-being, that's part of our health. And for our animals to be healthy, we have to be healthy as practitioners, right? And if we're seen as cogs in the machine or cogs in the wheel, the way corporate has it, that there's a sustainability issue there inherently with the system. I know you have some thoughts about corporate practice beyond what you've already said. Is there anything else you'd like to kind of add to that conversation?
Yeah, I think it's a double-edged sword. I think there's corporations that I have heard really great things about and support their doctors and really allow their doctors to practice medicine that they should be practicing, that high quality medicine. And they are able to really get you the things that you need to get. They are able to get those expensive machines and equipment that, especially as a specialist, we really need to do our practice. So you have that, but on the other hand, you are again stuck in a corporate cog in the machine, as you said, and some are better than others at really realizing that you're a person and you have individual needs. Some are better than others at really that humanity aspect of it.
Yeah, absolutely. It is really tough for specialists because a neurologist needing an MRI, I don't have an answer to how an individual neurologist can own an MRI or I
Exactly.
suppose they could actually refer to some other centralized facility, but it's different. It's a little bit of a different thing.
It's a lot harder.
Heard.
So
Yeah.
it's a lot more difficult. As an internist, we don't have that much equipment. We have our ultrasound and then we have endoscopy equipment. And really, what our main thing that we use is our brain as internists. We don't have the fancy equipment and do all the fancy tests, or we do the tests, but we use our brain. We don't have one big machine that we use or all these fancy instruments or things like that. So it's a little bit easier as an internist, I think, to break away from that. But it's also something that's, and maybe there's other ways that other specialists, I know that there are the ability to refer out and have neurology only practices. I have a friend who does neurology and he has a neurology only practice and he owns it himself and built it himself. So there is the ability to do that.
That's amazing. I think you're kind of highlighting the fact that we have creative means to actually do it ourselves. There's a lot of barriers for specialists, in my opinion, to doing that, but it's not impossible, as you've demonstrated. And as you mentioned, your neurologist friend, that's so cool. I mean, we are smart people, we are intelligent as veterinarians, and business entrepreneurship is not any different. It's easier. In fact, it's far easier than the practice of veterinary medicine, in my opinion. And so I love when I see people getting creative and doing entrepreneurially creative things and finding a way to make it work because we're capable of that. We're an extremely capable cohort of human beings. And so, I mean, specialists, especially, you guys have had even more training. So, I think thinking outside the box and figuring out how to make things work for you is not outside the reach of any of us veterinarians and especially not specialists. But it is a unique challenge that you guys have to overcome. And I respect that. I understand that for sure. So I'd love to hear, how's it going since you opened in March?
It's slowly building. We're slowly building practices. Word of mouth has been really good. So for referrals, we've got a couple practices added last week, couple practices added this week. So our goal is that once we work with a practice once, that they really have such a good experience with it that they are happy to use us again. And we really work for that. So we try and make sure that reports are written really quickly, that their staff is treated with respect, of course, that we have our prices to where they still can earn money from it. So that's also what we want to make sure they understand is that they still are able to earn that money. So I think once they do see how we work and how easy it is, then I do feel like that's how we start to get return practices. And that's how we're building our base of practices.
Yeah, that's amazing. And so what you guys are doing is you're doing some house call and so, going into people's homes. I understand primarily that's my referrals. And then you also go mobile to different clinics. Is that right? So now you're primarily mobile to other clinics and providing services for other vets.
That's correct. And then we're going to be starting to do some clinic days also in some clinics where I am going back to seeing patients myself, seeing clients myself, because I really do like that aspect of veterinary medicine. I love managing an IMHA case, and I don't get that as a mobile doctor. But if we do short periods, I can physically do it, I can mentally do it. It's something that keeps my skills fresh. I like doing it. And it's a nice way to add to what we're offering as far as our services go.
Yeah, that's amazing. It makes me very happy to know you like an IMHA case because if I see that kind of thing pop up in one of my clients, I'm like running for the hills. I'm like, please God, no.
Yeah, those are the ones that I enjoy. I must like punishment and
Yeah.
figure out.
Clearly you do.
Be a good autoimmune case, and I'm
Oh,
happy. So
that's
yeah,
excellent. That's excellent. We were discussing a little bit earlier today how we have such complementary skill sets and knowledge bases, and I wanted to delve into that a little bit more. So you were mentioning something about the urinary guidelines that came out. I don't know, you had mentioned something and I was like, man, you're a genius. And you were like, well, you're a genius at other things. And I thought that was worth discussing because as more information comes out and more content comes out about spectrum of care and acknowledging the realities of how veterinary medicine works and the vastness of the amount of information and paradigms and technology that we now have available to us. You had mentioned, we can't do everything. No one of us can be an expert at every single aspect of veterinary medicine. And so I wanted to kind of hear a little bit more from you on that topic because I think it's really, really important for all of us, especially mobile vets who are doing a little bit more in the general practice realm or in the holistic or integrative realm. we're really targeted in what we do. We don't do x-rays at home. We don't do surgery at home. Some of us do if we have a mobile unit, or some of us are super brave and they'll do like a tail amputation on a kitchen table. With the circumstances being completely under control, it has to be the right patient, the right client, the expectations have to be completely clear, etc. But there's so many mobile vets who get a little bit worried. There's a lot of people, myself included, when I first started, I'm not a real vet because I'm not doing XYZ. I've gotten over that by a lot, but it's such a common way for mobile vets to feel because many of us left traditional veterinary practice because of some painful experience. And some of us feel that maybe we're quote unquote giving up on veterinary medicine. And I simply want to disagree with that wholeheartedly. And I think kind of circle back around to what you were saying, that we don't all have to do the same thing. In fact, we cannot all do the same thing. It's not possible. So can you tell me a little bit more about how you think of that specialization versus, the things you do versus the things I do?
Yeah, I think that's really good because I think that there needs to be more of this understanding. And I think with some specialists and some GPs there is, but others have more of an antagonistic relationship. And there's no reason for that. There's no reason that one person needs to be a great surgeon and a great ophthalmologist and a great dermatologist and a great internist. You can't be an expert in everything. I'm not an expert in even everything in my field. There's still a lot of topics that I'm not comfortable with or that I haven't dealt with. And there are people that are even subspecialists with that, with some of these things. So even as an internist, even though I'm specialized, there's specialties within specialties.
You're very special. Can I just say that?
Oh, well, thank you. Special in a different way.
Yes,
Uh,
yes.
but that's okay. So there's specialties within specialties, and I recognize that I don't know everything about internal medicine, and I will never know everything about internal medicine, and that's okay. That's why we have other people to ask or to refer to because I do refer. I've referred to some of the universities for equipment or for some of these people who are top in their field because I would rather the patient get appropriate care. If I don't know how to do it, I'm just going to back away. And I think that keeping the patient in mind is more important than keeping our ego in mind.
Brava.
And I think that gets lost. I will tell people right away if people will say, like, well, my vet didn't know how to do this. I'll say, but I don't know how to vaccinate an animal. I
Yes.
don't know how to do a skin scraping if you have an itchy animal. So, like, the basic stuff that people will ask me, I don't know how to do. So, no, your vet didn't know how to dive into all of this complicated treatment, but they shouldn't be expected to do that. That's why I'm here. I have to ask them for help when I'm doing things myself. So when my cat has an ulcer, I was like, what do I do? I don't know. I have to go to somebody for that. So that doesn't mean that I'm not a good vet or I'm not good at what I do. It just means that I don't know that area. And that's okay. You can't know every area.
It sure is. It sure is okay. And there's two things that what you just said kind of reminded for me. One of them is I've had a number of vets who come from ER practice and then go through the House Call Vet Academy with the goal of maybe providing some vaccines. And they're like terrified. They're like, oh my God, I can do a splenectomy and like I could do a thoracocentesis and place a chest tube and save a pneumothorax, but I don't know what vaccines to give. And people are freaked out. It's not like a one-time thing. It's like over and over again. Anytime I get someone through the academy who used to work ER, I swear to you, they're so freaked about the vaccines and what the vaccine protocols are and all this stuff. And honestly, I went through the same thing because my background is I am residency trained in surgery. And when I got out of that, which obviously didn't work out, I was like, "Oh, crap. Now I have to know all the things that I don't know about." And it worked out, it worked out. You do something enough times with enough support in enough iterations that you learn what needs to be done. And I think you said, how many ultrasounds have you done at this point?
I gathered probably at least 6,000.
Yeah.
So yeah,
But
on
probably
yeah, it's in the thousands. Yeah.
yeah. That probably makes you more adept at ultrasound than the average Joe. And that's why I would never, I don't know. But anyway, I'm just happy you're around. I'm just really happy that you're here ultrasounding my cat and my patients. And, it's just great. And I also wanted to thank you for your collegiality and warmness as a specialist collaborating with a general practitioner. And I want to say that I think we all know that there's this antagonistic thing. You sort of alluded to it, that between specialists, general practitioners, between specialists and integrative or holistic practitioners, between every angle of, how we can do the stuff we do. And I recently had an experience that just really bothered me. And I've been meaning to catch up with you about this, but since we're on the air, I may as well tell you the story now. I have a concierge patient who I've been working with for many years at this point. We've built a really solid rapport. We're friends at this point, like I go to her home a couple times a month and work on her dog. And this animal has very severe allergies. We've tried everything Western, everything Eastern, everything integrative of every level. And this animal ended up getting a perianal fistula, getting put on a variety of meds. The client was previously afraid to start atopica, but we had to at this point because of the bleeding fistula. So at the same time that atopica was started, ketoconazole was started as well. And my patient ended up having like really, really, really severe gingival hyperplasia, like bleeding gums, like painful to eat. And I was like, okay, like we're healed up now, your butthole is fine. And you already got your tacrolimus ointment and everything is going well. Let's see if we can start tapering down. A few days later, my patient got a severe ear infection and became acutely deaf. And I was out of town, so I referred to another local colleague who I trust and love. That colleague came, treated the infection, and made some recommendations. Client ended up wanting to pursue specialty care to see if there's anything else we could do to get the hearing back. And this specialist threw both of us under the bus, me and my colleague. She said, well, what that other colleague did probably made it worse. And I wish that your primary vet, Dr. Eve Harrison, had talked to me first before discontinuing the ketoconazole because that's not how we do it. And meanwhile, this all implies potentially to my client that the hearing loss and the infection happened because I discontinued the ketoconazole prior to discontinuing the atopica. She wanted it that you taper them both at the same time. Fine, that's a great way to do it, but it's not the way. There is no gold standard for how to taper. I thought I was being very conservative and thoughtful of the animal to do a taper of the atopica to begin with. Ketoconazole, you don't need to taper typically. None of these drugs had been on for very, very long. There was an implication that both me and my colleague, also in Los Angeles, had done wrong by this dog. And it made me so angry. But, it was just that there was a lot to it. And, like I felt it endangered my relationship with my client. So, it created a little bit of an issue that I had to talk to my client about, like I almost called this person, but I was like, this is a mentality she has. A person like that, it's an entire paradigm she's been immersed in that I'm not going to fix. Maybe with the right person, they might say, oh my goodness, I didn't realize that would get back to you. I'm sorry, and I'll never do it again. And they might really mean it. But my intuition was, given the way it played out, the whole circumstance was that this is not a person who trusts that other people might also know what they're doing. And so I figured I would talk about it with you today on the podcast because I think talking about this publicly as a concept is where change can happen, right? Just letting people know how it feels. I think that's more in the spirit of activism and change to discuss in a public way the concept rather than to come at an individual and ask for an apology. You know what I mean? So yeah, that's my long-winded story there.
Yeah, I've been thrown under the bus by GPs also.
Yeah.
So, I think a lot of us probably have experienced that because
Yeah.
other GPs will do the same thing. And
Yeah.
I don't think it's correct ever. I do see some things where there's questionable choices or things that really have made my job more difficult that I do wish that a practitioner would have called or asked or waited or referred earlier. That's more of what I would like is a referral earlier before the case gets really muddled, but it's not something I would going to tell the client. Not something I'm going to bring up and purposefully say. And I don't like it when the client gets upset at their primary veterinarian for something, especially if it's something that the primary veterinarian, didn't do anything wrong. But even if they did, I don't want that relationship between them and the primary veterinarian to sour. Very rarely have I seen something that is just egregious, that is just a really, really, the medicine is just really bad enough that I'm concerned. I had one case where it was like that, where I was reading through the record as a referral and things were done that were basically things that could have gone to the board for board complaints. And I actually called that practitioner and said, "Hey, I'm concerned that these things happened. I'm not going to bring it up to the client, but I just want you to be aware that there's some really bad things that happen and multiple people touch this case, but this is something that you should know that this is not a good thing to do." But still, even then, I'm still not going to come to the client and be like, "Your doctor messed this case up completely." It's not my responsibility to do that. It's a tricky situation because I do feel like sometimes there are people who have done something that really is medically harmful. And we don't want to be that person who throws somebody under the bus. So we want to support the client because the client sometimes is rightfully upset. I think that's less common. I have to say that there is something that is just that really happens, but I have seen that. And in that situation, we try and kind of dance around that. But I'm not okay with anybody doing that. It's just not okay. It's just there's no reason to do that also. Like you said, if you have concerns, she probably could have called you and said, "Hey, this is why I think that this tapering, which I've never heard of, but for her to say, this is why I think that this is a better way to do it, and maybe offer her to, yes, be available to call because you can't just say, "Oh, I wish someone would have called me," and then not want to take calls. So
Yeah.
that's also not okay. And I was always would rather have a practitioner call me and ask, should they refer? What should they do and should they not do before they refer? I would much rather spend 5, 10 minutes on the phone with a practitioner than have a case come either too late or has already been so muddled that I'm backtracking. The client spent a lot of money. There's been delay in treatment. I would much rather get on the phone with somebody and just say, "Hey, I think you need to refer them. Here's X, Y, and Z, what you should do in the meantime."
I admire that so much. There's so much integrity there. I love what you mentioned about, the case where you saw borderline or full on malpractice and you contacted them directly. That is an honest way to approach something and with integrity. You didn't just ignore it. You for the sake of the animal and for the vet, you contacted them. You put yourself out there and risked them being mad or not liking what you had to say, and that took some risk and some sacrifice. And at the same time, you didn't throw that vet under the bus to the client. You didn't call the board. I know some vets like to throw each other under the bus by calling the board on each other too. That's very ugly to me. I don't think there's hardly anything, save for intentional animal abuse, that I would call the board. The board is not on our side. The board is here not for the purpose of veterinarians and to make veterinary medicine better. That is not the purpose of the board. And so I think when I hear about people coming from a holier than thou place, or I have to put other people down to make it super clear how good of a vet I am and how I knew that was wrong, and playing the whole tattletale game, whether it's to the board, whether it's to the client, I got this sense of, when I've been thrown under the bus before, and it's happened numerous times, it's a problem in our profession, right? I don't know any vet who hasn't been thrown under the bus other than the vets who are doing the throwing themselves. Maybe they've been thrown under the bus too. Maybe that's why they do it more. They're like playing the same game. I don't know, but it's ugly. It's really ugly. And my kind of theory about it is there's so much imposter syndrome, there's so much pain, and there's so much insecurity in our profession, the people who practice veterinary medicine, due to our education, due to the way clients treat us, the way we're devalued financially, that we're all struggling so hard and in so many ways to build ourselves up and to rebuild our sense of self-esteem and confidence in what we do, that some of us have just gotten these maladaptive techniques and they have to put other people down, other vets, point out how wise and smart they are to observe someone else is doing the wrong thing and earn the respect of the client by pointing that out. like they earn the client's trust by being like, oh, that vet didn't really know what they're doing. But it's very interesting. And I just hope that for anyone that might be listening to this episode, if you've ever caught yourself throwing someone under the bus or you've been under the bus yourself, to just kind of bring some mindfulness to that and think about where it may be coming from and how we can work together as a community to try and make that better. And I think, kind of your approach, Tara, is a beautiful step in the right direction. I wish all specialists would be like you.
I mean, I do see when I do see things that have set things back, what I always tell the clients is it's okay. Like we'll go on, or I'll pull out the same. That's okay. They're not an expert at this, but I'm not an expert at vaccines. So really put it to where that I'm not this so much smarter, but I do know this particular aspect of veterinary medicine better, but they know other things. So it's not like they're an invaluable person or invaluable vet and you should just discard them. It's not that. It's that I happen to be an expert on one thing that they are not. And so, of course, I'm going to treat things maybe a little bit more advanced. And maybe they didn't know that to not start this before this. And maybe when they get my record, they'll see that. So there can be some learning on the side of the GPs also of how things should be, really how standard of care is for specialty medicine. Again, when to refer, when to start medications before you refer, things like that. I think that there's a lot of education that could be given in a way that's not talking down to anybody, but is really saying, here's how we can help the patient the best. You can get this case that is falling apart off your hands because you can go back to doing things that you probably like doing better than having this sick, decrepit animal.
It's
You
like
can
the
get
IMHA.
exactly like the IMHAs and the things
Take it off
falling
your hands
apart.
right now.
But then I can take that and then that's going to be the best thing for the animal. And then once the animal's better, they're going to go back to you for all the other things. So it's not a matter of talking down to somebody, but we all do CE, or we should.
Mhm.
I learn things. I learn new things on how to better treat things as an internist. And I don't think that there's anything wrong with a GP learning from a specialist. They're not going to, of course, be an expert at it, but maybe there's some things that they learn, like, oh, maybe I should refer before this happens. And then next time they'll be like, okay. And so there could be some
Yeah.
easy things there that doesn't have to put anybody down or make anybody feel like they're not a good vet.
Yeah. Can I hear what you have to say? Maybe are there like a few common situations? You mentioned like, don't put this med with this medication or do this first before you do this. Can you think of off the top of your head, maybe like two or three examples of most common, like start the pred and then send them in for the for the endoscopy? Is that one of
That's probably the most common one that I see is the jump to the prednisone, jump to the steroids, especially for the cats. It's nothing on the blood work. They have a GI signs. Here's your steroid. And it's so much more nuanced than that. First of all, you're skipping a whole diagnostic. You're skipping abdominal ultrasound. Not everything's IBD or lymphoma. There's other things in the abdomen that could cause this to happen. And I'm surprised all the time. I think something's going to be IBD and I find it a big tumor. So you
Mhm.
can't just say, here's your steroid and everything's going to be good. The other thing that when they put them on the steroid, I think there's a lack of education on the downside of that.
Mm.
So steroids can affect the biopsy. So if we wanted to do a biopsy, steroids can affect that and it can really blunt that response on microscopic analysis. So what could be a raging lymphoma, you have them on steroids, it comes back as mild inflammation. And
Oh,
that's because of the pretreatment. And the problem with that is that they don't tell the client that necessarily. They've had the cat on steroids for, 3 months. The cat's not getting better because it probably has lymphoma. And then they come to me and want me to do an endoscopy. By that time, the cat is so sick that taking it off steroids is going to just make it spiral. And then I'm back to saying, I don't know what's going on. And I don't really like throwing chemotherapy at something without a diagnosis of either severe inflammatory disease or cancer. I can't just throw it and say, here's hope for the best. So that's probably the biggest one that I see. And a lot of it is just not also telling the clients. The clients don't know this. And really, if the clients are not doing referral, they're like, I don't want to do referral. I don't want to do anything else. And then you're like, okay, well, here's your steroids. Good luck. That's absolutely fine. That's not the situation that I'm talking about. This is the situation where they've waited to refer after they put them on steroids and the clients are willing to do an endoscopy. that makes my job much harder. That puts more pressure on the clients because then the client has to wait. The cat has to be off medication that maybe was making the cat feel better. And so now we just set ourselves back by several weeks. And we're hoping also that the steroids are out of the system and the disease is going to show up on the scope. And it may or may not. So it can really, really complicate. And that's probably the biggest one that I do see. So I think for things like that, where we may be affecting something, fevers. So patients that come in with fevers and then automatically get put on antibiotics and we don't have a urine sample. That's something also that just makes our job so much more difficult because we automatically put them on antibiotics and now we don't know what's going on or what's treating. Haven't gotten our sample,
Mhm.
haven't gotten things appropriately done. And it would have taken just maybe a little bit more time to do, or they're not going to die if they have a fever. The antibiotic course, yeah, maybe it'll help, but maybe you're picking the wrong antibiotic. And would it just be better to wait 12 hours, make sure you manage the fever, and then get the case done appropriately? And that's probably the better. I mean, very rarely are we like, you need antibiotics or you're going to die right now. Very rarely do we say that unless they're septic. So those are kind of the things I think that I would see the most that really can impact patient care.
Yeah, that makes complete sense. And I can see how that would be very frustrating for you that you wouldn't be able to have the gratification of providing the next level of care that is the purpose of the specialist. Like the patient comes to you and you're like, well, my hands are a little bit tied right now. And I can see how that would be frustrating for you as a practitioner and frustrating on behalf of the patient to just not have that information to be able to help them. So I think that's really good information for folks to know. I suspect that more often than not, the clients are declining the referral and the vet is like, whatever, and not documenting it. That's what I suspect is happening
Right.
more often than not.
And
When
that's a big one, I think, for us as if I see a case that's automatically on steroids, I'm like, why did you put it on steroids? But if you write a note that's like, it's nice to see in the record, like client declined, client, because then I'm prepared that I'm going to offer something that the client's going to decline.
right,
So I
right.
already feel like, well, this is probably going to be useless, but it's nice to see that because it's nice to know that the medicine was done correctly, that the
Mhm.
practitioner was appropriate in what they were doing, and that they really did try and do everything. And it's really the client that's tying the practitioner's hand and they're trying to do the best they can. So
Right.
even little notes like that, I think really do make a specialist feel like, oh, okay, this vet did do the best thing as opposed to, well, they just put it on steroids and they just like, here's your steroids. Like the old time vets, just here's your steroids and go away. And I think if a specialist sees that, we're a little bit like, what the heck? Versus client decline, client decline, client decline. And you're like, I can see what happened here.
Totally. That's a very interesting point. So, kind of from my perspective, what it seems like might be a good paradigm for kind of healing some of the rifts between general practitioners and specialists might be a combination of one, assuming best intent, and two, communicating to the best of our ability via the medical record. When it's the client that's thrown one of us under the bus and said, well, they never told me that. Sometimes it's the client that throws us under the bus. So when we communicate via the medical record to any specialist that we might be referring to, I think that can ease and soothe the collaboration so that there's an understanding of why things were done in the way they were. Um,
So important because the client so many times will come and say, I was never offered that. And you see it right in the medical record.
yep.
It's been going on for 3 weeks. And it's like, well, 3 years ago, this started. So we see that documented in the medical record. I mean, normally I'm going to assume that that's the client that's just making things up just because that's typically more what happens. But it's nice to see in the record that no, the vet is doing absolutely everything right. And you can say that to the client. I do say that. I was like, your vet did absolutely everything right.
I love that.
So there's nothing wrong with saying that because it's the client who really didn't do everything right.
Mhm.
And so they know that your vet did something right. They recommended it. You declined, so you did the wrong thing. It's
That's
on
a
you.
me.
Yeah, so I think having the records and that's just such a big thing I think for specialists anyway, is having medical records that are clear, that are concise, that really tell us what
Right.
was
Yes.
done, what the problems were, what you found, did you find something or what, not to say high ALT and not give us the blood work. Like that doesn't help us. So like complete medical records, I think for a specialist are just especially for an internist where I
Yeah.
look at every detail,
Yeah.
which is so important for me. And it also shows that the veterinarian, really, we do see the ones that are the good veterinarians who are doing the great medicine are the ones who are documenting all of this and are writing these things down. And those are the ones that generally have the best medicine and are up to date with everything and do everything correctly.
That's awesome. Okay. That's really helpful. So we talked a little bit about UTI and infection, and we had been talking about this a little bit this morning as well with my cat Maggie, who's diabetic. Do you want to give us a little insight into your brain, your little algorithm on how and when you treat a UTI and what your process is when you think about these issues from the
Yeah,
perspective of an internist?
Yeah, so from an internist, these are new guidelines that are scary at first. I think the idea of not treating something that has a bacteria makes us all very nervous, but I promise you it's okay. So really what we see a lot, and this is coming from human research in human women, where I think they say 30% of women have bacteria normally in their urine. And it's not that they have an infection all this time. They're not just sitting here with the UTI. The bacteria is just sitting there. It's not causing an immune response. It's not causing any issues. So there's no symptoms. So that's a subclinical colonization. That's not anything we care about. And we see the same thing in animals. So we can see just random enterococcus or random E. coli just in the urine, and the patient is not clinical. And I've gotten referrals where like we keep seeing enterococcus, we keep seeing it over and over, and we're like treating them all these antibiotics, and it's getting more and more and more resistant, but the patient's never had any clinical signs. And I just tell them to ignore it. And it sounds like, well, but don't we need to treat this really gnarly infection? And it's like, well, no, because it's not doing anything. It's not reacting. The body is not treating it as an infection. It's treating it as a commensal organism that just sits there and doesn't do anything. So that's kind of the new way. And that is for a lot of antibiotic resistance. So it's just appropriate antibiotic use is to really follow guidelines on when do we need antibiotics and not. We don't want to keep throwing antibiotics at things that don't have an infection. And also to use the lowest antibiotic strength that we can. So use amoxicillin. There's nothing wrong with amoxicillin. We all reach for clavamox. We don't need clavamox a lot of the time. If you have a UTI, amoxicillin is probably going to get most of the E. coli's. If you have leptospirosis, you don't need clavamox. You can use amoxicillin initially. So you don't need that conjugated portion of it that makes it a stronger antibiotic because we don't want to get resistance to that clavamox. So start with the amoxicillin, start with even the TMS, and you're only treating for 3 to 5 days now. It's a very, very short period of time. So the idea of having something happen, even if you're using something like TMS in that time, very low. But those are kind of the new guidelines that have come out. And so it's just a new way of thinking about these urine situations that can be really complicated. And even for our cases that we used to think had propensity to have a UTI, like our diabetics or our cushingoid patients, we're really finding that there's no reason to treat these guys. We still can treat them as if this is a subclinical colonization. There's no evidence that it ascends into the kidneys and causes pyelonephritis. It isn't. So the idea of us just doing antibiotics just because we're concerned or culturing because we're concerned, I stopped culturing routinely a lot of these cases because I'm not going to treat it unless the patient is actually symptomatic.
That's amazing. I love a good antibiotic stewardship stance. I love that. I mean,
Yeah.
the less antibiotics we can use, the better. I mean, it's pretty awesome. I haven't been treating a whole lot of UTIs in my practice, but Maggie is a diabetic, so I kind of keep my eye out for that. So just really, really cool. And then I also wanted to hear, like, what are your thoughts on IBD these days? Got any brain pearl wisdoms for us on IBD?
Well, it also depends on dogs versus cats. So they don't behave the same. IBD in dogs versus IBD in cats. They're not going to behave the same. They kind of have two different clinical courses. I treat them differently. I don't treat them as one disease process. So in dogs, we do have a good amount of these patients that we're now seeing with new research that are responding to diet change alone. Even the ones that do have low albumin have been reported to respond to diet change alone, which is brand new research that just came out at ACDIM. And that's fantastic. So the idea of using a diet first and not jumping to having to do an endoscopy is fantastic. I think cats are a little different though. Cats, oftentimes we're seeing them because they're not eating as part of this. And so it's really hard to get a cat to do a diet change when it's not eating. And then again, we don't really know how often cats are responding to just diet. For me, anecdotally, I feel like just diet alone, they are much less likely to respond than a dog. So I feel like just anecdotally, maybe in conjunction with a steroid might be a little bit better option, but just as like a sole treatment, just anecdotally, I've not had really good luck with that. And so I am going to be probably more apt to push for biopsies in a cat. And it really does direct my treatment. Some people say, well, if it's lymphoma or IBD, you're going to put it on like steroids. Well, that's yes, but no, because some cases you can get away with a mild steroid like budesonide, but some IBD cases don't respond to budesonide. So that's a difference. Some cases can't be on prednisone, or you don't want them on prednisone, or some cases don't even respond to prednisone by itself. So some of these IBD cases aren't necessarily full blown lymphoma, or maybe are lymphoma, but they're piecemeal and we're not finding them. And we've got them on steroids and we have a diagnosis already of severe IBD. So we feel comfortable about putting them on that chemotherapy as opposed to not having a diagnosis, failing steroids, and really saying, is there something else going on? Is this something that could be chemo? And then what if they fail chlorambucil? Because some of our small cell lymphoma cats fail chlorambucil. Well, now we really don't have a diagnosis. Now we're going to reach for a stronger chemotherapy. Now we're really in a big hole that we've dug ourselves. So that's why I really do like the endoscopic biopsies. Now, not every cat can undergo anesthesia. So some cats have renal failure, right? Those are probably not the best ones. Some cats can't be on prednisolone, so you're going to try budesonide anyway. So there are animals that don't do endoscopic biopsies or the owners, financially can't afford it. I think those cases, trying a steroid is going to be your next best bet. But I think you have to realize that you have to tell the owner the limitation. And as long as the owner makes that decision and they know, then you're good. I've had clients who have refused endoscopic biopsies, have failed prednisolone, and have come back a year later and been like, well, what do I do? And you're like, well, I told you this is going to affect the biopsies. Your cat's too sick to taper it off prednisolone. So we're in a bad situation. So I have had that happen. But if you inform the clients, I think that you don't get as much buyer's remorse from that when they choose just the empirical treatment.
Buyer's remorse. Yeah, I mean, there can be a lot of buyer's remorse in veterinary medicine, right? That's interesting.
Definitely.
Yeah. Very cool. We discussed a ton of subjects just now, and I love what you had to say on so many of these topics. Is there anything else before we sort of start to wind down that you'd like to share with listeners from the House Call Vet Cafe, whether it's a message to other mobile vets or other specialists who are interested in doing this, or, just the vet community at large? Anything that you'd like to say?
I think the vet community at large, I think we're tired.
Yeah,
We're overworked, we're tired, we're probably underappreciated, and that goes for the support staff as well.
sure does.
And I think there is becoming more of a sense of we're not feeling valued by the people who are running these practices. And so I think there is maybe a point where it's just going to come to, we're not going to want to work for these practices. We should feel valued. We really shouldn't feel like you dread going to work on Sunday. We got into this profession because we really liked it. And not every day is going to be fantastic, but it shouldn't be just exhausting mentally, physically. That's just not a good quality of life. And we don't deserve that. None of us deserve that.
Mm. Yeah, thank you for sharing that. And do you have any thoughts on how we as a community can address that or make it better for ourselves?
That's a good question because I think it's really hard when we're talking about, well, how do we get vets to own practices now or groups of vets because they're coming out with so much debt. So I think until we're starting to change the whole veterinary school system and how much it costs and veterinary salaries, I think until we really change that, it's going to be very hard for us to escape and to really be able to start owning practices again. And I think the veterinary medicine as a whole probably has to go through some big shift of something to really get us to wake up about the debt for the students that they're coming out of. And it's just not sustainable. Something has to be done. And I think if something's done about that, you're going to start to see more of these ability to have a clinic, run a clinic, have a big specialty hospital, not need to rely on a large private hedge fund to pay, because some of these are private hedge funds that own these
Penny,
specialty hospitals.
penny.
Yeah, exactly. And so, I mean, I don't want to work for a hedge fund. I've never wanted to work for a hedge fund. That's why I'm not in finance. So I think that until we really change maybe even the very beginning, I think it's going to be very hard for us to do that. So something has to shift in our mentality.
Yeah. Yeah, I love that. And I very much agree that this is a systemic problem. We know that it's the system and that it starts early. So you're talking about starting from vet school. So I think that we need to potentially shift our attention to the early part of our careers and the very beginning of the road. And then I think until we can shift that on the systemic level, I do what I do because when we start a solo or a tiny micro business, like a house call practice, we're not in this tremendous debt and the risks are lower. The stakes are much less. And we have so much more power. And so I think there's a combination of kind of encouraging people, teaching people, letting them know they can do this. And also for the folks that have incredible debt and simply cannot, we have to do the work earlier on in the kind of pathophysiology of how this all has come to be the way it has. So thank you very much for sharing that perspective and kind of taking it back to the core and like the root of where it all starts. As they say in the holistic world, the root of the problem. So awesome. I'm so glad you're here today with me. Thank you for ultrasounding my cat Maggie this morning. And in closing, I wanted to ask, what's your favorite beverage to drink since we are in a cafe right now?
But what's our favorite beverage? I'm a big boring water drinker. I have to drink like liters of water a day. So you will find me with my giant glass or my giant bottle of water, not flavored, just boring. I drink coffee, I drink soda, but I am a big water drinker and I know that's very boring, but it makes me physically feel so much better and it's healthier and there's no calories. So I don't need extra calories in my, but
Me neither.
I eat enough of those.
That's awesome. Water is life. It's not boring. Water is the source of all things. So that's awesome. Thank you for sharing that. Thank you for all of what you do and your insight into the dumpster fire that is veterinary medicine. And I'm just super happy to have you in the mobile vet community. Welcome. And I'm just really glad you're here. And I will see you at my next ultrasound referral.
Definitely. Thank you so much, Eve, for having me.
You're welcome. Thank you so much for listening to this episode of the House Call Vet Cafe. If you enjoyed this episode, then hit the subscribe or follow button on Apple Podcasts, Spotify, Google Podcasts, YouTube, or wherever you listen to podcasts so you never have to miss an episode. This podcast is made specifically for you, so don't be shy if you'd like to reach out and let me know your thoughts on this episode. You can find me on Instagram and Facebook as the House Call Vet Academy, where I also share more valuable content. If you're interested in learning more about consulting for house call vets or the House Call Vet Academy online course and community, please click on the link in the show notes. Have an amazing rest of your day, and I can't wait for you to join us for our next episode of the House Call Vet Cafe.
If you're looking for help with ultrasound scanning, check out First Opinion Veterinary Ultrasound for independent machine reviews and online and in-person teaching options. FOVU, simplifying ultrasound.